Yes, sir, we are good to go.
Hello, good evening, everyone. Greetings and warm welcome for today's panel discussion on optimizing labor and delivery. We are delighted to have uh, all panelists here. And on behalf of BSV team, I, Prasad Kulkarni, once again extend a warm welcome to our moderator, our esteemed panelists, and all the delegates who have joined us today. Doctors, BSV is known for biological, biotech, as well as pharmaceutical products. Today, we influence patients out in all therapeutic areas of women's health, critical care, IUI, and IVF with wide range of innovative products. Without much ado, we are going to commence this webinar today, marked by a cherished tradition, that is lamp lighting.
Yeah. कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
As we know, a lamp symbolizes knowledge, wisdom, and enlightenment. The lighting a lamp before a function, before a webinar, is a symbolic gesture to seek blessing from Almighty and also symbolizes the commencement of event and invoke positive vibes. With that, I would like to invite our esteemed faculty, our moderator for today's panel discussion, Dr. Komal Chavan ma'am, who is a medical director at Chavan Maternity and Nursing Home, a senior consultant, DNB teacher, and unit chief at VN Desai Hospital, Mumbai, and ex-honorary professor, Dr. R.N. Cooper Hospital, HBD Medical College. Ma'am has got many credentials, starting with she's now currently Vice President elect FOXI 2025, Zonal Coordinator FOXI for President 2022-2023, Core Committee of Violence Against Doctor Cell FOXI 2022-2023, Governing Council Member ICOG 2024-2026, and Chairperson Amox Family Welfare and MTP Committee, and many more in her credentials.
Thank you.
Yeah, ma'am. So these are the few awards which I have to take here, which is a very prestigious award, marked by Dr. Rishma Dillonpai, Personality of the Year 2023, FOXI Mr. Rene Pandit and Mrs. Shailaja Pandit, Women Empowerment Award 2022, and many more. She is also editor of many journals and books, and for the reviewer for many publications and the journals. I heartily welcome you, ma'am, for this panel discussion as moderator.
Thank you. Thank you so much.
Next, I welcome Dr. Abha Sinha, ma'am, who is the principal at SKMC Muzaffarpur, professor at Muzaffar College, treasurer ISOPA 2022-2024, ICOG Governing Council member 2021-2023, and many more credentials to her witty. I welcome you, Dr. Abha, ma'am.
Thank you. Thank you.
Ma'am, Dr. Achla, ma'am, consultant OBGYN at Mata Gujari Hospital, Delhi, and currently she's heading the national president at NARCHI 2022 and 2024, and president at NARCHI Delhi 2019 and 21, and president at AOGD 2019 and 20. And she has chaired many conferences and many publications, and especially to note here, the author of workbook of obstetrics and master trainer of WHO for RSC and RMC, and awardee of Abdul Kalam Award 2019. Welcome you, ma'am. Welcome for this panel discussion. Now I call upon Dr. Mitra Saxena, ma'am, chairperson for Practical Obstetric Committee, Foxy 2021-2024, a senior consultant in private practice of Rewari, Haryana, active Foxy member from last 20 years, and past president and now patron of Rewari Obstetric and Gynecological Society. We welcome you, ma'am, for panel discussion. And Dr. Sandhya Saran, past president, Thane OB-GYN Society, and Honorable Joint Secretary for PCOS Society of India. Special interest she has in the endoscopy, PCOS, infertility, as well as in yoga. We welcome Dr. Sandhya ma'am here, and Dr. Nivedita Jha, Associate Professor at Pondicherry, and South Zone Coordinator for Foxy, Clinical Research Committee 2019-21, Communicator for Core Faculty, Foxy CRC 2022 and till date. And ma'am has got a wide interest in different areas, and especially to note here is publications is more than 50 papers in high impact international journals. We welcome you, Nivedita ma'am. And Dr. Munjal Pandya, Associate Professor at Narendra Modi Medical College, Ahmedabad, Gujarat, and Honorable Secretary of Ahmedabad Obstetric Gynecological Society for 2021 and 2022, and received a Shri Zaftari Young Talent Award from AOGS for the year 2017 and 18. He was also co-edited book on male infertility in January 2019. Winner of Dr. Kamini Rao West Zone Yuva Foxy Oration for the year 2021. And he has got, along with the academics, has got many other hobbies like painting, guitar, singing, writing, tennis, and photography. We heartily welcome you all, the moderator and all the panelists here. Thank you, ma'am. Over to you, ma'am.
Yes, thank you so much, Mr. Prasad and the team BSV for this very comprehensive webinar and on the topic of day-to-day interest, that is optimizing labor and delivery. I think we all look into our practice and we really want good outcome when it comes to a patient who is there for a delivery. Like today, I had a patient whom we were planning to induce, and the patient just got a fear and she just went into tears. कि मेरा operation तो नहीं होगा, and she started crying. So when we try to counsel our patients, we need to see their psychology also, because so much is known. They have that fear, they have the phobia before the process starts. And when the process is going on, they still have so many dilemma. And we as obstetrician, we need to just optimize and give good outcome. It's not like you're calling that this delivery is something which is normal or abnormal. No, everything I explained to her that the mode of the delivery is everything is normal. It is just a vaginal birth or a cesarean birth, and everything is considered normal. So when you become pregnant, you should be prepared for all that, because we cannot say that it is going to be normal today, or nothing can be termed as abnormal. But when they have a fear of labor. Sometimes we have a crying patient with a labor ward. She says, I can't bear anymore. Please take me to the OT, and she will deliver beautifully. When you counsel her after 3-4 hours, you see that she is the one who delivers. Everything is rotated, and then we find that she delivers next day morning. We see her in the ward smiling with a normally delivered. So it's all the obstetrician's role to counsel the patient depending on their clinical finding, and that is the idea behind the panel. And thank you, my esteemed panel. I have learneds from every corner of India, and I'm so thankful, Dr. They're professors, they are the teachers. They have been guiding students, and so many students are benefited by their knowledge. So we have Dr. Abharani Sinha, who is joined from Patna Muzaffarpur College, Dr. Achla Batra from Delhi, and Mitra Saxena, who is currently the chair of the Practical Obstetric Committee, and she has taken up this initiative to teach the obstetrics, and that also to revive certain things in obstetrics, and she's doing it beautifully. Dr. Nivedita Jha from Pondicherry, a very good academician, and dear friend Sandhya Saharan, who will be joining, and Munjal Pandya. I think he is a very young person, but has a real good experience in obstetrics concern, and he has worked in my committee. So I'm really thankful for the panel, and I'll just share my slide and we'll begin with the panel discussion. So I'll make this full screen, and is my slide seen? Yeah. Is it seen?
Yes,
Yes,
ma'am.
ma'am.
Yeah.
Make it full
Just make it
screen.
full
Full
screen.
screen.
It's not full screen.
Okay. ठीक
Yeah,
है?
now.
Yeah.
Yeah. So we'll just start with the panel. We all know what is labor. I think we know that it is a physiological process. It is nothing abnormal. It is perceived as labor pains. And we discuss the anxiety, fear, stress, whatever. We try to relieve it, giving a verbal analgesia or giving a labor analgesia, but everything we try to do so that we facilitate a good outcome. That is what is the idea which we always aim for. And in the recent times, we all have alarming, there are so many circulars or something that the cesarean rates are rising. And every time we introspect the next day, like I can actually connect with all the people working in an institution that if there is an emergency going on the next day morning, we are more interested in the primary sections which are done and why they landed up, because there may not be a better induction done to them. Was it justifiable induction? Was the augmentation and monitoring carried out properly? And that is what we go back and try to see whether that was an indicated cesarean section. So this is our concern and we are doing our bit. But there is quality, there is awareness, and we also are binded by certain things which we cannot prevent. Everybody wants to have safe outcomes and they really want good outcomes. And we tend to always do what is good for the patient, giving good outcome in cesarean section, that is the good outcome of mother and baby. But what we need to know is the age old. Are we inducing patients on the right time? This is really very important, because there may be so many induction of patients, but they have a particular induction at particular time. Like you cannot have a premature induction which can lead to premature distress, and then you landed up taking a patient for cesarean section. So indication should always be a right, whatever is your indication for cesarean, and then we begin with. So my first question will be to Dr. Abha Sinha. What are the different methods of induction? You decide upon induction, because induction of labor itself is a panel. So I'm not going on the indications for induction, but you have clinically decided that this patient needs induction. So what are the different methods of induction, and what generally you will do? Like it's a low risk patient to a high risk patient.
Okay. Komal, thank you for asking this question. Well, before going for induction of labor, as you rightly said, the indication should be proper. And the second point is that which method to be used. That definitely depends upon the Bishop's code. If the cervix is unripe, we usually use some pharmacological method, and prostaglandins which are used, which can be either in the form of PGE1, that is misoprostol tablets, or PGE2 gel, that is dinoprostol, that we are using mostly. In case of a ripe cervix or slightly dilatable cervix, even we had been using oxytocin directly, but these days it's the prostaglandins that we are using, except for cases which are previous section cases. In previous section, we avoid prostaglandins. We do not like to use prostaglandins, and there we can go for mechanical methods. And the mechanical methods could be either use of a laminaria tent or a synthetic tents also these days we get, or some type of osmotic dilator, or we can use even Foley's catheter. We have found good results even with Foley's catheter when we have used in patients with previous cesarean section. Or age-old methods like stripping the membranes and amniotomy. But yes, here is a word of caution. We should never use amniotomy for intrauterine fetal death. Surgical induction is contraindicated for patients with intrauterine fetal death because of the risk of infections. And extra amniotic saline infusion, well, that is not used these days. But yes, Foley's catheter we are using. And apart from this, I think these are the methods: medical, that is pharmacological, mechanical, and surgical, that is amniotomy, which is rarely used these days.
Yes. You perfectly said that we really have sometimes you take it a chance that you want to try a non-pharmacological method before you start a pharmacological method. Sometimes you use combination also. Have you used combination methods anytime?
Yes, we are using mifepristone in cases of IUD. Like before, for 24 hours before, we are giving a dose of mifepristone, and then we are calling the patient next day for misoprostol. And that works really well for patients with intrauterine fetal death. It really works well.
Yes, I think priming first with an mifepristone and then misoprostol, it works. And at times, even amniotomy, which we do and augment the labor with
amniotomy.
oxytocin, that
That
also
helps in
convinces.
augmentation of the labor. Once the cervix becomes ripe, and we do the amniotomy, then there is quick augmentation of the labor.
Yes. So these are very well summed, the methods of induction, because many a times, we feel that the induction is not working properly, and they call it as an induction failure. So when will you actually call it as an induction failure, Dr. Abha?
I think we should give enough of time. It's not that we start induction and after 4 or 6 hours we call it a failed induction and we just terminate it by C-section. I think that is not proper. We should look at the uterine contractions. If there are contractions a week, we should follow up with augmentation with oxytocin and just try to patient to take at least 12 to 16 hours, and then only we can say. And pain relief is very important during this period because pain relief, it helps to shorten the labor, and that is an important part of, and monitoring of the labor is also important. I think whenever we are doing an induction, it should be a full-hearted indication, not
Yes.
a half-hearted that we are just starting the induction and then straight away going to section.
Yes, that full-hearted is a very important point actually. When you decide upon induction, you should do it completely and you should do justice to the induction, what you have planned. And definitely after induction comes augmentation. And Dr. Achla, your views on augmentation, what is the recommended way to augment and what is actually not recommended when we actually augment?
The augmentation is different from induction. Augmentation, when we are doing, is that labor has started, but we
Yes.
feel that it is not, it is slow. So then already she has contraction, but they are not causing any change. Then it is augmentation, and augmentation we most of the time we do with oxytocin only, because we already either patient has had spontaneous labor or we've used something to induce labor, not oxytocin, but some misoprost or maybe gel of dinoprost. But then the labor is not progressing well, then we augment with oxytocin, and that really helps to accelerate labor.
How much duration you will wait from like you have induced, like Dr. Abha now she has induced a patient, she's given an over to you. So the patient, how, like, what will be your duration? How much time you'll wait before you start the augmentation?
If once the labor pains have started, and after 4 to 6 hours, nothing much is happening, they're not increasing in intensity
Yes.
and duration, then I would like to augment.
Yes, actually this was a very simple question, but it is very important that you need to wait. Like if a seniors, what they'll tell you is that you need to wait for 4 to 6 hours. It is not so sudden that you start doing, because we really want to be sure that we don't cause uterine hyperstimulation, and that is actually the cause of fetal asphyxia or even the rupture uterus what we have. So we need
Dr. Komal, can I add something?
Yes, Dr. Mitra, yes.
Yeah, I just want to say thank you for including me in your wonderful panel. And actually, it's always a two-way process. While we are telling our experience, we are also learning so many things from our moderator and co-panelists. I just want to give my bit, and that is to begin with, like Dr. Abha said, the induction should be very valid. And then when we are inducing, the main focus in my personal practice is the change in the Bishop score. You know, the Bishop score is our guiding light. So from where are we starting and where we have reached. So whatever ripening agent we are using, Dr. Achla has already written a very good protocol for induction of labor. So the ripening agent, whatever we are using, we can safely use it at least 2 or 3 times. And unless there is no change in ripening, no change in the cervical score, we cannot call anything like failed induction or something. Also,
Yes.
sometimes we may have to give a rest. If the baby is well oxygenated, we may like to, and the membranes are not ruptured, we may give it a break under supervision and then carry on another after 12 hours or 24 hours. Like induction should be valid, baby should be well oxygenated, and our methods should be well, safely used. So that's my thing about ripening, and everything depends on the change in the cervical, dilatation, effacement, station, rotation. So labor forces have to be evaluated whether we are doing induction or we are doing augmentation.
Yes, absolutely. We need to go. That is a Bishop score, and we need to constantly evaluate our patient. And recommended practices when we do an augmentation, maintaining a partograph, giving the patient the mobility, the upright position, the patient can move around, that is very important. Uh, Timely starting oxytocin and amniotomy as and when required. All this is very important and very few, but you can't do a frequent digital examination that one resident come has done, the second one is doing. So all that. I think Dr. Sandhya has joined and she has raised her hand. So Dr. Sandhya, you can add.
Yes, thank you so Komal for adding in here. And I raised my hand because you mentioned partograms. As you
Yes.
know, I'm a big proponent of partograms. I have devised my own also, and they were universally accepted. So that is one thing which is very important because nowadays, even for medical legal purposes, a partogram is imperative. So many a times what we do is we just don't document what we have seen. Especially like Dr. Mitra mentioned, there's nothing like failed induction, and if you are keeping everything a record properly, so this will go very hand in hand to help us evaluate the patient for further prognosis.
Yes, I think that partogram is something which is so important that it is the must practice which we follow. And Foxy, when we are advocating, we are using the partogram, but we are advocating even for the smaller nursing home, the private sector, to maintain a partograph, because that is a time where we'll know that we are actually doing right. And it is medico legally, as you said, it becomes very important to know that when you have you acted on time, and the delay, everything is all there, black and white, mentioned on the paper. So it's a very important document. And definitely augmentation, we need to take in care so many things, and sometimes even administration of enema, but this may not be an augmentation. They are just things which we try to keep using it. They may not give, but we want to clear the bowels, we don't want. So these are the way just to assist the normal delivery, but they should not be considered as practice for just augmenting the labor. That is the point. This slide is there. So moving on, uh, my slide is not moving. Okay, so now coming to the program labor. So this is for you, Dr. Mitra, or even Dr. Sandhya, you can add into it. So what is program labor? Like, this concept was introduced earlier, and I have been very fortunate, Dr. Daftari, and he has actually captioned this. And there were a lot many workshops which have happened all over India. And program labor is a concept very convenient for a doctor to deliver a patient. She comes in the morning, she delivers by night, and everything is all planned. So, Dr. Mitra, can you just throw light on this?
Yeah. I'm also very fortunate that Dr. Daftari had shared all his studies with me, because when I was appealing to become this. So fact of the matter is, program labor, actually it focused on ensuring that there were good uterine contractions so that the power is good and there is pain relief. Two most important things in programmed labor is that if the uterine contractions are good, obviously whenever we are keeping a patient for delivery vaginally, CPD would have been ruled out.
Yes.
And then it's mainly because of no pain relief that the patient becomes very, very anxious, and all the delay happens. So basically, the most important pillars of program labor are that the patient is admitted, and within stipulated time, the patient delivers, successfully, because of two main things. That is, the pain relief is very adequate, and there is ensuring that the power is very good. I mean, like, it's not that this patient is having hypotonia and then you're waiting endlessly. So that is that you start and you finish at an end point. That is what is programmed labor, and very successfully conducted by under Dr. Daftari. So, but yes, in our part of the country, we haven't done this. Yes, in medical colleges or wherever there are too many patients in labor ring ward. And at one time when we had pethidine available with naloxone, we also used to give good pain relief by pethidine and timely presence of nalorphine. And this is Dr. Sandhya, you can add whatever you want to.
I think Sandhya, because we have worked and she must have worked and have a first-hand experience. So I wanted Dr. Sandhya's views.
Yes, we worked with Dr. Daftari, and we were part of the group where they would, we would have a big clock, in fact, hanging over there. And sir would tell us, okay, at this time we, augment the labor. If the patient has, she's come in early labor, augment the labor. And then at that point of time, we used to use ketamine. Now,
Yeah.
of course, there are a lot of, people who are wary about using ketamine, but we have seen such excellent results because, patient is very comfortable. And we always counsel them before itself that after the patient delivers, she will behave a bit weirdly. So we used to tell the relatives that don't get worried. And there was total compliance and acceptance and wonderful results. Within, say, 6 to 8 hours, the patient would deliver. And we never had any unforeseen like complications like tears or anything, no precipitate labor, nothing. So everything was programmed, monitored. Augmentation, various things, sometimes we used to use a gel also. We have used a lot of dinoproston gel. At that time, it had just come in. So sir would use different kinds of modalities. Of course, Pitocin is something which we have used since we were residents. But this is something I wanted to share that, immediately, and how he used to talk to the patients. You talk to them, you keep telling them what is going to, very important, and keep the patient in the loop. You tell them now this is going to happen to you, and then this is what we are going to do. So then what happens is the patient is very comfortable and compliant, and things go very, very, it's like clockwork precision.
Yes,
Actually, for many years, Dr. Komal and all others, we have been using Dr. A.K. Devdas's guidance, and that is once the patient is in active labor. That means, of course, now the definition has changed to 4 to 5 centimeters, but in our times, the practice used to be fully phased and 4 centimeters thin, well applied, and good contractions every 3 minutes. We could, we could extrapolate that in the next 6 hours patient will deliver. Of course, now because they do not encourage augmentation, so they have allowed longer time, that it's no longer that the rate of dilatation should be 1 centimeter per hour. But our general extrapolation used to be, if she's 4 centimeters fully phased, very good contractions every 3 minutes lasting for 40 seconds or so, then patient will deliver. She should within 6 hours, or at least after 3 hours. If you do an assessment, there should be a change in the dilatation and station and rotation. At least in one direction, there should be progress.
Yeah, we need to monitor progress. So that is very, very important. I think you all have really summed it very well, because it all depends upon the clinical monitoring, talking to the patient, because we want to give her the verbal analgesia. We need to keep her in confidence so that the pain relief also works, and ensuring that patient is getting a good uterine activity. And this is very important. Dr. Sandhya has actually thrown light on the 5 Ps, but you can add anything is remaining, Dr. Sandhya.
Yeah, and of course, what I forgot to mention, which I thought was early amniotomy. See, when the patient used to be 3 centimeters and she used to have good contractions, we would definitely do an amniotomy so that, you see the liquor, and she progresses very fast compared to, like, if you leave the membranes intact, then they are a little slow. But once you do an amniotomy, 2 advantages. Once the head comes down easily, and the assessment of the liquor, which of course is again useful in the partogram. So in the components of the labor, we have first of all the passenger. Passenger is the most important, that is the fetus, and the afterbirth, that is the placenta. So you have to ensure what is the lie of the fetus, the station, all that has to be first documented. It cannot be that the station is high up or something of that sort. So everything has to be proper for a normal labor. Station, the lie of the fetus, and then of course you come to the canal, whether it is adequate. The pelvimetry, at least nowadays we don't do X-ray pelvimetry, what we used to do before, but a physical pelvimetry is very important, to check whether the issue is fine, what is the distance, so that you don't land up with the CPD, because these are contraindications. So that is, you have to rule out any contraindications. Then what is the contractions? What is the kind of uterine contractions? If there are no contractions, or if she's having very, very feeble contractions, then definitely she's not going to progress. So then you know whether you need to augment or what you need to do, so that you maintain that rate of progress of the cervical dilatation and this. And of course, the mothers. Like, we had recently had a conference in Mumbai itself, where they had demonstrated that in the, on all fours, if the mother is on all fours,
Yes.
how easily the delivery happens, a normal delivery. In fact, that was study being done by the French doctor.
Frank Loven had come, yeah. He did give an oration that delivering a breech on all fours. Absolutely.
Yes, reach on
Yes.
all fours, which is something which was something like a miraculous. It was looking like a science fiction, but definitely that is a position where he says anybody can deliver. So that is important. And even I have physically tried a lot of women in the squatting position, though it is very difficult, but they deliver very easy. So try not to deliver them in the supine position. That is, I think, the most difficult position for the fetus, but at least a little bit of we can have a little bit of propped up, if not completely sitting. So that is very important. And of course, like we said, anxiety. All women are anxious. Nobody wants a normal delivery. In fact, I just had a patient who she said anything but not a normal delivery. So you need to tell them that this is a natural process. There is going to be pain, but we have labor analgesia. So we have so many things in the armamentarium to help them deliver normally.
Yeah, and we are now thinking on these lines only when we are talking about respectful maternal care. We are allowing the mother to take the position of choice, to ease out her anxiety, communicate with patient, and that are the components. So important is that we treat the patient as whole. Yes,
I
Dr.
want to know, this program labor is all about pain relief with pentazocine and pethidine and augmentation with oxytocin if the contractions are feeble. But now that we have the epidural, which is so good,
Yeah,
so
we
I
are going to
suppose
speak about that. Yes.
these drugs, which probably can cause depression of the fetus, and we don't have. Suppose we're using pethidine and we don't have nalorphine, so that has to be taken with a pinch of salt. I think when
Definitely we are going to talk. We're just analyzing things.
it was good, but now we have very easily available epidural. So I don't know if program labor should be used or should not be used.
So we are not talking about pros on anything. We are trying to analyze what is the journey, what are our experience now, how we have come, and how we adapt
Recently,
to the
there
newer
has
things.
been three centers. 2015 has used this program labor,
Yes.
and they have said they had good results. But I have no personal experience, so I can't say.
No,
But
we are saying that it is a way. We are not saying that you use all the drugs, but some components, some learnings from there, and we need to adapt to the
pain
newer
relief
times.
is
Yeah.
the pain relief part is really something which has which helps.
Madam, but what happened, this was more, around 15, 20 years back, because many centers, like we are in metros, so we have access to anesthetists, we have so many. But there are many centers in smaller towns, and in, they if they learn this, then for them it is easy for the obstetrician itself to do it, because they cannot rely on having an anesthetist all the time. So that is for them, basically.
Yes. So
actually, Dr. Sandhya is very right. In a smaller city, we don't get anesthetists to put a epidural. But what I'm relying mainly is on Drotin and on Tramadol. Like I haven't got much experience now. It's also very difficult to monitor narcotics. So pentazocine and all is all.
That's my point. It's difficult to monitor narcotics, though the dose used in the program labor is really very small.
Very small, yeah.
1/5 or 1/10 of doses. But since I don't have personal experience, so I think
Yeah, but
people who
there was one consultant in our city. She used to use fentanyl and pentazocine combination, and she used to always manage to deliver her patients vaginally. But my personal thing is this, that like Dr. Komal has said, speak to the patient. Verbal analgesia works like magic. And just stand with them. कभी कैजोल करो, कभी डांट भी लगा दो, प्यार प्यार से हो जाता है, provided she is having good contractions. The problem happens when the power is failing and there is no progress, protracted labor, so she gets exhausted. So we have to actually really
that
check
premature
whether there is
bearing
something
down
else.
is very dangerous. They try to bear down early, and then they're totally exhausted when they actually need to bear down. So that is so important. So moving on now, why are we talking now, Dr. Nivedita? You want to highlight what are the advantages of these active management. When we are doing this management, is it benefiting the patient, the baby, to the obstetrician? What is it?
Yeah, ma'am. Thank you for this going to the answer per se, we'll pay tribute to O'Driscoll. In 1975, way back, he published his paper, prospective observational study, where he applied this bundle of care active management, and in 100 people who were on expectant, like don't do anything approach, and the external outcomes were way better, significantly better in this protocolized approach. So now, as it is now universal practice to follow this. And the most important advantage is that it shortens the delivery time, at the same time optimized outcome. So these bundles, it should be practiced one after the other. So first thing in this comes the diagnosis of labor. If we find patient is in false labor, she can be sent back home. But if she's in true labor, then we have to monitor her closely, monitor by partogram, and do examination for thoroughly. Examination can be done even oftener, every 2 hours also, if in active labor or cases where we suspect dystocia, like if the baby is big or something. And once patient reaches second stage, PV should be done early to pick up arrest disorders. So vaginal examination is a very important part of that, and monitor. Then taking care of patient's nutrition. She can be allowed oral as long as she is in a latent phase, and hydration is very important. Then taking care of a sedation and labor analgesia. So epidural analgesia is not they rampant everywhere. So we manage up with tramadol 50 mg 8 hourly intramuscular dose. Then most important part of this active management of labor is early amniotomy. So studies have been done on early versus late amniotomy, and we have found good results with early amniotomy, like as Dr. Saharan Madam also said, no, you pick up the color of the LICA, and then it helps the head also settle, impact, and progression of the delivery is faster. So early amniotomy, and after amniotomy, if contractions are not adequate, we start oxytocin for augmentation. So this bundle of care should be practiced. And in O'Driscoll's study, he found that if this bundle of care protocolized approach is followed, patients deliver within 12 hours. So earlier, the adage was sun should not set twice for a woman in labor. So it took almost 24 hours. But O'Driscoll in 1975, he brought the concept that within 12 hours, a primey should deliver. So this is the advantage. All said.
But I think now we are coming to a concept where there is an ACOG and the SFM criteria where they, because of the sizing rate of cesarean, and it is being proposed that you need to wait, the failed induction should not be, and the active labor starts when the patient becomes more than 4, is becoming 6. That concepts are coming into, and even for primary gravida, you made for more than 3 hours, for full more 3K is becoming 4 hours. So all this is coming. So what now? I think we should coin it that sun should not set more than twice for the patient who is in active labor, rather than calling, because the latent labor can be really long, and we need not be so impatient. So
actually, I have also now very
but
recently
active labor should not last very long, and I think it's always a circle. I've seen over the years, whatever we've been doing, things change, and
Like
then we come
fashion.
back to square one. I think this 1975 will come back again one day. You mark my words.
Actually, I wanted to just share that of late, for last couple of months, because I have my own ultrasound, I've started looking at the, like nobody should put me in PNDT. This is off the record. But during labor, I don't actually do an ultrasound, but I definitely confirm the position of the baby on an ultrasound. And I have found that the ROTs, they will go into labor later. They will take a protracted time. So if they're well oxygenated, the babies, and the cervix gets effaced nicely, they do go into labor. But our, the waiting time for ROPs is we always learned it traditionally, but when we translate it in a patient in labor, we get unduly, anxious. So, for my own self, I have started having confirmed, clinically, yes, we know we can make out the side of the baby and the fetal heart, everything we can make out by clinical examination. But yes, if we have the ultrasound, just have a look and then just stay put. If the color flow is good, CPR is more than 1, chill, patient labor seh jayega, bachcha seh jayega. My main contention is that vaginal delivery should not be a trauma for the baby. So if the baby is well oxygenated by CTG, by color Doppler, and then the labor has to take its time. So we have to be patient.
I
No,
think
that
the
is very
position part
important, I
is
think.
very important. And when we were monitoring in our times 30 bags as a resident, we always used to write the position. But now when I see the resident,
They don't, ma'am, they don't.
and then they don't know if the paid labor is prolonged, why it is so. Later on, it becomes, difficult.
Yes.
So that practice should come back,
Dr.
Uh,
Abha,
and-
your views, what
Yeah.
about the residents there at Patna? Are they like, how do you follow about the labor and the monitoring?
Monitoring is by partogram. I'm in an institution and there we are advocating partogram for each and every patient. And we are starting the partogram after the active phase of labor. But actually now this labor care guide has come, which has been developed by Arun Kumaran. So still we are not following that labor care guide. Still we are following the usual partogram. And like waiting, we don't have that, strict monitoring because we have loads and loads of patients.
Patient,
So it's
that
not
was my
possible
point.
to look after each patient one to one. So we are just following the partogram, the old one that we were doing, the WHO partogram.
मैडम मुझे लगता है कि गवर्नमेंट हॉस्पिटल में because there are so many patients ना, so by the time you finish one patient, the other patient is ready for delivery.
These days,
Yeah,
the
in
residents are
private, what
very
happens
fast
is
in
you're
finishing
monitoring
things
one-on-one,
and
you're so
I think
anxious.
Dr. Mitra, they are doing one section in 45 minutes.
I
They
know.
are very fast. Gone are those days when in our time we used to take 1 hour, 1.5 hours to do a section in early days.
You know now, like when I post emergency, when I go, I tell my juniors, section everybody does. You deliver vaginally and tell me how many you deliver.
Yeah,
Now there is
very
a
good.
challenge, and last emergency everybody delivered vaginally. So it's a happy day. Maybe the anesthetists are not happy, but we are very happy. So it is that way. Like now there is a challenge to them that they need to deliver vaginally.
True.
Yes.
So this is
Because
how
of
now we need to.
litigation also, I think so. Because of litigation, I think we are going more for C-sections. In our times, I think हम लोग कहते थे कि अगर तुमको vaginally deliver करना है तो medical college में आ जाओ क्योंकि private में वो लोग cesarean करें. But now everybody is afraid. Everybody is in apprehension that if we try given a chance for normal delivery, then the baby may be asphyxiated. Then the relatives and party they come and tell you why you got her delivered vaginally. So these days, because of litigations, also we are having more of
Very
C-sections.
important. Even IUFD patient will cry that do a section. So what do we do? So
No,
this is
we
very,
definitely
how
we have
it
to
becomes very-
counsel. We have to counsel, but still they are just after us. Jaldi kara do nahi to jahar
Jaldi
phail
kara.
jaye.
So IUFD patient will tell ki you write and give कि patient को कुछ होगा नहीं. Now we take in writing. They are asking in writing if we wait. So this is how the situation are changed, and doctors are always under so much pressure. And when we have to give our good, and we have certain things, I think Dr. Munjal is not there. We'll move forward about program labor. So we have already spoken about the active phase of labor and shortening. I think this is all been discussed. The cervical dilatation when it becomes more than 4, the contractions good, taking the CPD. So also we will go to the medication. Now, Dr. Abha, to you, like we are not talking about the classical program labor, but when we talk about something you want to program now in your recent times, like there were views about tramadol, there were views about rotavirine, there were earlier concepts where we use epidosin, we use buscopan. So what are general medications which you have used and which are used in your practice with good results?
Well, we also had one workshop on program labor. Dr. Kanan Yalikar, I think at that time she was the vice president of Foxy, and she had come to our institution. And if we just talk about the traditional program labor, they were using everything, right from giving this thing, Fortwin, that is pentazocine, diazepam, then ketamine also, along with that rotavirine and tramadol. This was what was all used, and ERM was done as soon as the patient went into labor. Then the color of the liquor was seen, and accordingly the program labor was started. But in clinical practice, we are not giving ketamine. Nobody is giving ketamine.
Yes.
And the point is that the best is epidural analgesia. Analgesia, there's no doubt about we don't have the provision of giving epidural analgesia to each and every patient. I think for them, the subtherapeutic dose, which was described in the programmed labor, like use of pentazocine 1/5 of the usual dose. That is 6 milligram of pentazocine and 2 milligram of diazepam. I think that can go, still it can go, because we had done many cases by that protocol and we did not find baby getting asphyxiated or there were no floppy baby syndrome or respiratory distress in the baby. So I think that still can be followed. But the usual practice in our institution where we are not giving epidural analgesia in active phase is tramadol. We are still using tramadol and rotavirine. I think these are the two drugs that we are using. Epidocin, right, we had that experience about 15-20 years back. We were using epidocin half-hourly, 3 doses. That was the protocol. But as we were discussing earlier, there was a lot of flushing and tachycardia when we were using epidocin. And gradually, perhaps the drug was withdrawn or what, I don't know. But we stopped using epidocin and we moved more towards routine and tramadol. And
availability was the issue earlier. And I think very nicely you have summed that we really require the two things, that drugs, when we talk about analgesia, that is labor analgesia, which is the key, and the antispasmodics, and you have summed up everything so well. We really need to know what we are actually using practice, and you have highlighted so beautifully the tramadol, rotavirine, epidocin, everything. So now I think Dr. Achla was putting in a lot of views on labor analgesia, and I really want to know her inputs, how the labor analgesia and how is the procedure, because there are so many, Dr. Abbas said, in the medical college, it is not practically possible, the load of delivery you have for every patient to have the benefit of labor analgesia. But how do we optimize labor analgesia for all?
See, what's the advantage of labor analgesia is that when the patient gets pain relief, then the progress of labor is faster. Plus, when she is in pain, she will hyperventilate, she will have acidosis that can cause vasoconstriction, the blood flow to the baby decreases. And when the analgesia is there, especially when epidural is there, there's increase in the blood flow because of relaxation of the vessels. And even hypertensive patient, the BP remains stable. But rightly said, if possible, epidural, especially in a public sector, it is not possible. So there we are also using tramadol, and we were using epidocin and now rotavirine for not for analgesia, but for cervical, it is a relaxation of the cervical muscarinic fibers, and tramadol. But in my times, I remember we used to give pethidine to everybody and just make them sleep for a few hours, and when they would get up, they'll get up in active labor, good contractions. But now there's a lot of hue and cry about baby depression. So we stopped giving Fortwin and pethidine, and we're using tramadol. And labor analgesia really helps. I have personal experience. My daughter-in-law was in labor a few days back, and she said, "No, I can't bear it." And we put in epidural, and she was so happy for 8 hours, and she was fully dilated by the 8 hours from 3 centimeters. So analgesia does help.
What about all experience? What about the chances of instrumental delivery at the end? So is it common, or what do you see in your practice?
Yeah.
There is a slightly higher, because though the epidural is stopped at the time of pushing, but still some residual defect is there. So if you wait for some time, like now we say you can wait for 3 hours. And I think the most important thing is that once patient is fully dilated, doesn't mean we ask her to start pushing. That is what happens, There are 2 phases in the second stage also. One is when it is just the descent, and when it reaches the perineum, only then the expulsion starts. But the general practice is as soon as it is fully dilated, jor lagao. That's what causes more of instrumental deliveries, One should wait for 1 hour at least, for the head to descend before you start about instrumental delivery. Now it is not happening. But the full dilatation and jor laga is a cause of instrumental delivery. Otherwise, I don't think epidural would cause that.
No, but I think you are very right, Dr. Achla. It's mostly that the obstetricians, when they stand in front of the patient, that's their anxiety. And, whether it's a junior resident or a SR, whatever. So that is why they ask the patient. On the contrary, if the midwife is standing over there, she takes her time, she allows the patient to be in second stage, and wait for the expulsive phase. Personally, I have received pethidine. I was for VBAC. I've had previous cesarean for breech, and then when I was opting for VBAC, it was pethidine which did the trick, because at 6 to 7 centimeters, I was actually in very severe pain. But when my obstetrician came and gave me pethidine, then I was sleeping nicely and only ready for pushing at second stage. So I think pain relief, we really something better than anything which is available. I still feel that epidural is very invasive. You need to have very good monitoring. We still don't have the ideal analgesic for labor. I wish we had safer analgesics. Then a majority of patients would have delivered vaginally, So labor analgesia in practice, my personal experience is in earlier times, pethidine was fantastic. And we also had an antidote to it.
We actually need to
naloxone.
depend on anesthetists to give labor analgesia, and there are not many anesthetists who are very
Yeah,
into
that
this.
is what I'm saying.
That is the draw.
Labor
Yeah.
we are monitoring, but for analgesia we are dependent. I wish we were able to crack this code and
Yeah.
have some analgesic which was safe for the baby and complete pain relief for the mother. Let's hope there will be some good molecule, or maybe some TENS, and like even this oxygen and nitrous mixture, which second stage,
Yeah.
patients have used, and they have had very good, results. But it's, the confidence of the patient, the relatives, and the doctor in doing a successful vaginal delivery.
Yeah,
That
Dr.
pain
Nivedita,
is
you want to
unbearable.
add
Even for
something?
that oxygen and nitrous also, you need the anesthetist basically.
Yeah,
because
yeah. Of
I
course.
wanted to hear the
Other-
oxygen and nitrous only. Dr. Nivedita, you have any?
No, I said that oxygen and nitrous combination, the laughing
Yeah.
gas. Yeah.
We do use
Entonox.
Y'all use?
yes, at least 4 to 5 cases a month. But the disadvantage is that OT table is blocked. The patient has to be in OT when she is in second stage, and anesthetist stands by the side. So, so many cesareans are also waiting, but it's very good, and most patients deliver.
Yeah. In
separate-
private sector, if your husband is an anesthetist, Entonox is a very, very good modality used.
So yes, ma'am, it's good
Yeah.
actually.
That is a good combination for labor anesthesia. So coming to the role of valethamide bromide, I think everybody spoke, and now we are coming actually to the antispasmodic part of our panel. So Dr. Sandhya, I know you have seen the journey of all the antispasmodics. So particular role of valethamide bromide.
Yes, initially we used to use it like water, the moment
Water.
into Epidocin, even the staff used to, before we used to go, they used to give it. So Epidocin was something like, it is the trade name for this valethamide bromide. It is basically to shorten the first stage of labor, and it is a rapidly acting cholineolytic, spasmolytic, and musculotropic agent. So basically what happens is it relaxes the cervical musculature and helps in quick dilatation of the cervix, and also shortens the first stage of labor. So that is the only reason why we used to use it. But now, as madam has mentioned, that it used to cause a lot of flushing, because we used to give it 30 minutes apart. 3 doses was what we used to practice. So gradually many people have moved on to Drotin instead of giving valethamide bromide.
So I think we have grown up, and that term which you use like water, like we used to give top up. I remember we used to have a syringe full with Epidocin and Buscopan, and even staff used to keep it ready. So we used to ask the sister with oxytocin going on and give like a top up. And there are so many studies have shown the efficacy that it accelerated the labor. We used to get the pink card, which we used to get in medical colleges. And night, if you get a night call and you go in the night, you give drugs and the patient delivers. So, but the outcomes were that time good. We had a good progression to normal delivery. That was the main outcome. So this was accelerating. What about anybody wants to talk about the older time when they have used valethamide bromide? Anything which was favorable?
Yeah, we are all turncoats. हम
Used
सब
to
बदल
call it
गए
a
हैं.
magical drug.
We have
you
all
know.
grown up on
Give
Epidocin.
3
In our
doses
medical
and
college, we
patient
used to
would
use
deliver.
every 20-30 minutes 3 doses, and we used to swear by Epidocin कि हमारा बहुत जबरदस्त experience है. Only when in private practice, and when it became over abused, when you
I think
combine it
overabuse is a word.
with,
Yes.
Dotin or with this Buscopan, what happened was we were giving two drugs of the same side effect, and then it's kind of, at least I got scared and I stopped using it. For last 8-9 years I haven't used it.
It happened when the scare phobia came now when we had a scarred uterus coming, and the tachycardia which it causes, it's very difficult to know if it's a scar tenderness, and that is the time we started getting our, we used to give it, and the tachycardia was the one sign which was very profound. It used to come fast. And in the scar uterus, we were not able to know whether it is tachycardia related to impending dehiscence or what. And that was a time when we really thought. So that was one thing which I recollected in my residency. Dr. Achla, I think you wanted to add something.
No, I was just saying that call it a magic drug that will give 3 epidocin and definitely the cervix will dilate and patient would deliver. But I don't remember much about flushing and tachycardia with epidocin.
बहुत ज्यादा.
Yes.
I
Actually,
think
what happened is, Komal, at that time we had such a large volume. We were all residents. So at that time there was such a large volume of work that we would just give it to the patient and patient would deliver so easily. So there was no time to monitor tachycardia,
all that,
these
yes.
because anyways the patient is going to deliver, she is going to have a little bit of tachycardia. So
And
now
which is
not
I think that time period which was kept, that 30 minutes or 20 minutes period, so the tachycardia would come and it would settle, and
Yes.
probably when patient would be dilating also and progressing, so she is not bothered so much, and we were not so aware कि ये
Yes.
problem है. आज तो हम लोग हर चीज से जरा सा
Aware है.
tachycardia होता है लेबर में, तो हम we are all the
Yeah.
time imagining कि यार इसकी इको नहीं करा रखी, कुछ होना जाए.
Yes.
So
More
all that
beyond-
has come into picture actually.
Yeah.
Earlier
But
we
never mind.
maybe giving also earlier, and the tachycardia was the obstetrician's tachycardia also with it.
अभी तो
Abhi to, everything will give rise to tachycardia if you don't do right for our patients. So that is very important. Coming to Nivedita now, like we talked about the dilatation methods, which are like I think this was discussed little, but I want you to go more on detail about something which can mechanical or any other pharmacological methods to facilitate cervical dilation. Your experience at Chipmare.
Yeah, we are routinely Foley for all such thing in low risk or high risk. Because in high risk labor, Foley mechanical method is much more better because it doesn't cause uterine hypostimulation or sudden uterine contraction, so that all the oxygen is shunted to uterus. So patient and baby's oxygenation remains good when Foley catheter is used, and at the same time it gives very slow ripening and even goes on to causing uterine contraction and induction of labor. Many a time it's delivered with Foley catheter itself. So Foley.
Wow. So you put extra amniotic Foley's catheter the same way we used to put for the.
So we are using, but in previous cesarean section, because it requires the patient to be in bed for 6 hours. Extra amniotic saline, it goes through the infusion pump at a rate of 60 cc per hour. So almost 500 ml has to go in. So 6 hours she's in bed and constantly something is being leaked.
You put a saline
into the Foley infusion pump is instilled into the amniotic space. And my postgraduate is doing a thesis also in previous LSCS with Foley, and other arm is Foley with extra amniotic saline, EC.
One is only Foley's and one is Foley's with extra amniotic saline.
How much saline, Nivedita?
Ma'am, 500 ml saline
1
over.
pint.
So it goes at 50 cc per hour.
Okay. Through infusion pump?
And in we have seen induction to delivery interval really shortens with the use of this, but there are not many studies quoted in literature on extra amniotic saline. But Foley's, and it has not shown to cause increased intrauterine infection or choriotype. It's a very good mechanical dilator. And then prostaglandins, yes, PGE2, pessary also we use. Misoprostol, the good thing is that now it is FDA approved. 23 November, FIGO guideline has approved the use of misoprostol for FIGO and FDA, both, for the use in labor. So we can, hands down, we can use misoprostol now. So that we are using. And regarding augmentation, amniotomy and oxytocin is the only drug for augmentation.
Because I think now the gray zone is the scarred uterus. I think that was a very valid point which you made, that you are trying to now induce. So what about Dr. Abha, in your practice? Are you
For
using?
scarred uterus, we are not using extra amniotic saline. We are using.
But all our induction rate is 25%.
Foley's catheter. We are just inflating the bulb with around.
And giving traction
I
to the
think
Foley?
Yes, ma'am. We give traction.
Nivedita, you said it is FDA approved. It was FDA and Foxy approved, FIGO approved earlier also, but the
Oh, no.
DCI has it got approval from DCI from India? So
DGCI.
that is the only problem.
Director General drugs.
DCI approval is still not there.
Still not done.
So
No.
Still not there.
Still,
Yeah.
we still can't use it, lawfully. It is a very good drug. Everybody is using it. But if somebody questions, the DCI has still not approved it.
I want to ask of those of you who are in the medical college, have you used mifepristone in term for induction as a thesis for research
Yes.
purposes?
One research is going on in prime and
You're
start
doing-
Because
using
in
it for
Rohtak
full-term?
Medical College,
mifepristone.
in the last 3-4 years, they've had many studies where they have induced mifepristone for term pregnancies in the live baby, not IUD.
Not
IUD
live,
we are
not live.
using.
live for 24 hours, one arm Foley's, another arm mifepristone, and after 24 hours they continue with misoprostol or gel, as the case.
Because
may
I
be.
think
Live baby,
mifepristone is a
Nivedita,
very
for
good
live
ripening
baby.
agent.
But only for research purpose. It's not come in vogue now.
It is
Yeah.
not. I don't know about the approval to use in a live pregnancy.
Live
So
baby,
I have
we
not.
are not using. We are
not-
using only for IUFD.
Yeah, even I am using for IUFD. It works excellent.
Yeah, it works very well.
excellent. Very.
Madam, when we were studying, it used to be RU 486.
Yes.
Yeah.
yes.
Right. So that time we used to use it. We also had a lot of thesis papers and it was very effective. But
No,
yes, it is not being used routinely nowadays. We don't use it, but definitely it had good results.
Yeah. So there are so many medical colleges and there are so many trials. The mode to use, I think.
but-
Yeah.
So Foley is the best. I think everybody should start practice of Foley because the patient does not require intense monitoring for 24 hours and cervix ripens.
So if it is not a scarred uterus, do you use any other method after Foley's? Do you induce with prostaglandins, or it is not required?
Ma'am, Foley or extreme with oxytocin, nothing else.
Directly
No.
oxytocin after that.
Yes, low dose oxytocin for 8 to 12.
I
Because
think
scarred
that's
uterus,
a
we can't
method
use
worth
prostaglandin.
trying, Nivedita. We'll
Yes,
do it
the
from
Foley's,
some of my
madam, the Foley's just comes out. After 6 hours,
Yeah.
you'll see the Foley's coming out completely. The whole cervix opens up.
Opens
And
up.
then
middle
it-
trimester abortions, when
Yeah.
everything fails, give a rest of 24 hours and then put Foley's. It
I
helps.
think in 6 to 8 hours, the cervix dilates and the Foley's comes out on its own, in most of the cases.
Yes.
Yes. We have also used it very often, but in private, I don't use it much. But yes, in medical colleges, yes.
I have used Foley's only in desperate situations when everything else seems to have failed. And then I don't want to give any pharmacological agent and I just give 24 hours rest and then put a Foley's ki chalo ab ye kar lete hain,
Yeah.
before doing hysterotomy or anything. And
Right.
it works. It has
No,
worked.
I think it is a good. I have used earlier a lot of Foley's when we were doing in Cooper earlier, but now somehow we have seen, like, we don't use it as a first shot. You know, when we have prostaglandins, we try to use that. But for previous LACs, I definitely wanted Nivedita's inputs on it. I think it's a must try
It's
to use it.
It's a must do. Well, it's a must do. It's not a must try. It's a must do.
Must do rather
That
than
is the only method that should be tried.
yeah.
It's the only.
नहीं, but previous cesarean में भी मैंने mifepristone use किया हुआ है for induction. जैसे अगर IUD है और previous
IUD
cesarean है,
तो
मैंने
previous
IUD
two
is
also
okay.
we
IUD
use.
is
use
okay.
किया.
But for a live baby,
Live
still
में
only-
नहीं किया.
नहीं, लाइव में नहीं किया, लाइव में बिल्कुल नहीं किया है. और लाइव में मैं प्रीवियस सिजेरियन में इंडक्शन ही नहीं करती हूँ.
नहीं, आप
Spontaneous
बैलून
labor हो
डालो.
गया तो VBAC, नहीं तो
बैलून
cesarean.
डालो.
No
बैलून
induction
डालो.
with previous cesarean.
You'll be very happy. बैलून डालो.
When we should not use
जैसे प्रीवियस सिजेरियन में malformed बेबी हो गया, उसमें मैंने यूज किया है.
See, balloon is a very good method.
Yeah,
Yes.
balloon is a good method, and I
Yeah.
think this is really a good discussion
Good
because we
take home.
really want our patients to deliver faster. We want to induce labor. We want to augment. We want to use drugs, and we want to give them good outcome. That is very important because we don't want, like, nobody should say that we have not tried before taking out the patient for cesarean section. So very good inputs. I think each and every panelist has given a good input, and this was a last question, like which was more effective, dotraverine or valethamide bromide. So I think we have used both, and we have shared our experience about it. So anybody
Ma'am,
wants to add anything?
yeah, ma'am, during my postgraduate coaching, I have used it, but off-label, uncharted use of Buscopan or Valethamate. So it's not available in hospital supplies, but we give the prescription, patient gets from pharmacological store, and yes, it causes faster delivery. But what we have seen is lots of cervical tear. So this is personal experience, and one network meta-analysis. It was a company-sponsored trial by Nandita Palshetkar ma'am, published. That particular article we had discussed in our journal club in the department also, where they have compared RCT, Epidiosin, Rotin, one more Camilofin. So they have documented quicker delivery time, but then again cervical tear. It's a network large meta-analysis of 7 RCTs. Cervical tear was quite significant in those studies. That was the result that we had discussed. So, but if it is used sparingly and used with caution, like in desperate situations such as breach after coming head of the thing.
Certain indications where it can be used properly.
Yes. So desperately, it should not be like, no, okay, we can still, but it can be, how we give is a dilute form. So 2 ml of Buscopan, we dilute with 8 ml, 10 ml, and slowly over 10 minutes we inject. So it has not caused so much of, dryness of mouth and flushing and all that side effects. It has worked also. It works sometimes, but it's like on paper, we don't. So
yeah. So I know many trials are coming, and there is now a buzz that it is going to come back. So probably we will have a new protocol for use, because I think we need to take care of these aspects also, that we don't want patients to have any problem like cervical tear or anything what you have said. And we need to even try to optimize, you have used off label. There were some studies where comparisons were done. So we need to have newer studies, the dilution, the duration, everything needs to take into consideration. So I think everybody has given such lovely inputs. We really want to give a good intrapartum care to a patient. This 1 hour was an excellent discussion from all the learned panelists who have given their inputs to shorten the labor pain, give them substantial pain relief, decrease the blood loss, decrease all the stages of labor, simplified the obstetric management, lower the incidence of operative delivery, and give neonatal outcome. That is really very important message which everybody has given. I just want one line message from each panelist before we end this very, very comprehensive and a focused panel discussion. So to begin with, Dr. Abha, madam. Dr. Abha, madam. Madam, you're muted. Yeah.
Sorry. Sorry. Yes, so my final word would be that we should all strive to reduce the relief and proper monitoring of labor so that we can achieve or we can optimize labor and childbirth.
Okay. Absolutely. Thank you. Dr. Achla?
I think monitoring and all everybody would do. I think what we need to do is give psychological support and pain relief. That is going to go a long way in optimizing labor outcome. Rest of the things are all there in books, but this is something, this human angle is very important to understand. The psychology and the pain relief is very important.
Yes, that is very important. Now, I think the AI is going to come in obstetrics, but the human angle is the most important thing. Dr. Mitra?
Yeah, I think both Dr. Abha and Dr. Achla have given very valid points. For me, I would say that to optimize labor, the preparation begins in the antenatal period. So, it's not that last minute mein jaise kunji se last minute mein padke nahi kar sakte. The mental preparation of pain management with the relief, whatever medicines we have, otherwise also all the biofeedback and the involvement of the partner, understanding labor, so that, over a period of time, fear can be allayed. And during the course of antenatal visits, if they can meet your delivered patients who have delivered successfully, hand holding, these things make a lot of difference, at least in private setup, that patients get the confidence that if she can do it, I can do it. And finally, it's during the act of labor that patient has to be monitored very carefully, because while the mother and the baby need to be safe, even we have to see that nothing untoward happens during course of labor. So we cannot sit just like this ki aaram se baithe hain, kuch nahi, sab kuch theek hai. We have to be alert, but we have to optimize before she goes into labor. So mental preparation of the husband and patient antenatally as well. And of course, intrapartum, yes.
Yes,
To
very
see
important.
that the baby is starting with no negative oxygen deficit. If the baby to begin with in labor is jeopardized, we may not be able to achieve what we are set out to do. Thank you.
Okay, Dr. Sandhya.
Very important to keep the patient and the relatives in the loop. Informed consent is what I believe in today's day and age, because try as you might, whatever, sometimes they land up with the LSCS, and then we should just tell them that no false promises. I'll try only as long as this, and if it doesn't happen, then definitely be prepared for an LSCS, because otherwise they'll say aapne to bola tha and nahi hua. So that should not be the way. So it has to be a two-way communication, a very, very, proper discussion before you embark. Because nowadays, even if the baby lands up in NICU for a small even TTN, tachypnea or something, then they will say, no, something went wrong, you waited too long or something of that sort. So be very careful when you counsel them. And then, of course, monitoring and giving your best is very imperative.
Dr. Nivedita.
Ma'am, most of the points have already been said, but this is a chase project which the Foxy is doing with 50 centers. You are one of the mentors of that. All of
Yes.
you are mentors in that. So we have come up with a 4-pronged strategy. And I'm working on induction of labor module under Achla Batra ma'am. So these 4-pronged strategy, like how O'Driscoll gave active management of labor, this would be Foxy's protocolized approach, where proper induction of labor strategies, protocolized approach, integration of respectful maternity care, CTG, its interpretation, and
monitoring.
labor analgesia. So if 4 things are done properly, then there'll be optimized mother and baby outcome, at the same time reducing cesarean section rate.
Absolutely. I think you have covered everything what is required, and I think the audience must have really benefited, because it was from the people who are actually doing the groundwork, trying to make the guidelines and the trials. So this is from them, and we really, everybody wants to, what happens is that when we talk about labor, it becomes a common interest topic to everybody, and everybody wants to know how to go about and do their best. So thank you all the panelists who have joined, and your inputs were tremendous. Mr. Prasad is waiting from BSV. I think Dr. Niranjan Chavan also has joined, and we actually had invited one of an international faculty. I think she got busy and has sent her regards. Dr. Niranjan, do you want to speak anything?
Yeah. Thank you, Komal.
Yes. Want to video?
Hello.
They want to see you also. I think he must be in the meeting.
I'm in the I'm in the midst of something actually. Shanta just called me, so I said I'm in a webinar. I'm listening for a last half an hour, and I'm really happy that you have taken a wonderful topic of how to reduce the incidence of cesarean section. And today I had gone to the Foxy office, so CN Purandare sir was there, and I met Fionnuala McAfee. Very few of you might be knowing that she is the Ireland. She's from Ireland, Dublin, and she had come along with her 2 handsome prince. But both of them are non-gynacs, and they are doing something else like biotechnology. And so I met her also, and of course we had a general meeting, and there we were discussing. So I was actually thinking that she might join, because she has come to India for the vacation and then go to the AICOG. So, but I think she is little busy. But I really appreciate, the efforts which we are taking, and lot of, the induction of labor and all monitoring patient. Just to summarize, actually, I feel that we need to be more taking interest in our present generation, who can't be blamed also to certain extent, because I sometimes blame myself only. So I started going to the labor ward now and performing cesarean section and showing them lot of things which probably I could have done earlier. Because if we continue like this, after 10 years, out of 10 patients who come to us, 8 will be cesarean section, and it will not be good over a period of time. So that's what I feel. We should also be that much involved of training the newer generation. So Nivedita, Jipmer, how are you? All well,
Yes.
Achla?
Yes.
Yes, sir.
Yeah.
Thank you.
Thank you. So I think
So-
we actually had people from everywhere. We had Dr. Abha from Patna, Dr.
Yes.
Asha from Delhi, Dr. Mitra, who is the practical obstetric, so she's practically everywhere,
Yes.
and Dr. Nivedita from Jipmer, and Dr. Sandhya, who has the first-hand experience. She's worked with Dr. Daftari, and Dr. Munjal also, who is from Gujarat, and he couldn't join, but he also is in very close with Dr. Daftari. So we all wanted to discuss some common, and glad that Dr. Niranjan, who is at Sion. So this is like the Mumbai's biggest delivery area, and you also joined the panel. So it was great.
Yeah.
So I know that this all starts with labor, and we had this inputs of common interest people, and we are doing our bit, and we are hoping good. And they are all geared up to train our younger generation. I think that training which Foxy is giving, which the teachers are giving, is very, very vital to shape the future of obstetrics, I think. So I think with that note, thank you everybody, and I'll hand over to Prasad Kulkarni.
Thank you, ma'am. Thank you, everyone. And I must say, this was a very fantastic and
Dr. Achila wants to say
engaging.
something,
Dr.
Mr. Prasad.
Achila wants
Yeah,
to
Dr.
yeah.
Achila.
I want to
Hello.
say Happy New Year to everyone before
Yes,
we wind up.
Yes, yes, madam.
We wanted to
Dr. Achila,
end the
everyone.
New Year. Yeah. So Happy New Year to all of you. Yes.
Yes, from me
Yeah.
also.
Thank you, Komal. It was really
Thank
lovely
you.
to be with you and in the panel.
Thank you.
Excellent
ma'am.
panel. Thank you so much, all
Thank
of
you.
you.
Thank you, sir. Thanks for
Thank
your
you, Dr. Niranjan.
presence
Happy New
here
Year.
in this session. I take this opportunity to thank each and everyone who are part of this webinar. And we would like to express on behalf of BSV appreciation for the time and the effort our moderator and the panelists who have invested in preparing and delivering such an informative and engaging session. And I also thank all the participants for their active involvement and enthusiastic participation, and as well as our event partner RX Events. And as we continue to strive excellence in our educational initiatives, your contribution serves a source of inspiration for our team. And once again, we thank you for outstanding contribution to our webinar. We look forward to the possibility of collaborating with you all again in future.
Sure.
So advance wishing you a happy new year 2024. Signing off from BSV. Thank you.
Thank you. Thank you so much, and Happy
Thank
New
you.
Year to everybody. Have a great weekend, great start to a new year, and we all will meet in the new year soon.
Yes.
In
Looking forward
Hyderabad.
to meeting everybody at AICOG.
Yes,
Yeah.
everybody at AIC.
To Pondicherry, it's
Yes.
the best place
Yes.
for
Bye-bye.
Thank you.
Bye-bye.
Bye.
Komal.
Thank you.
Thank you so much.
Bye.
Bye-bye.
Bye-bye. Thank you, Dr. Niranjan.
Bye. Thank you,
Yes,
everybody.
madam.
Bye.
Thank you. Bye.
Bye.